You're listening to Informed Dissent. If you're a longtime listener, welcome back. If you're new, welcome, and here's the lay of the land. I'm Jamie Reed, a lesbian and a whistleblower who worked inside a pediatric gender center. My co-hosts are Lauren Legere, also a lesbian and a longtime LGB advocate. Our other co-host is Corey Cohn, a gay man who underwent gender transition early in his life. All three of us come from the left, and none of us fit the story you've been told about who questions gender medicine. And that's not an accident. Every week, we will cover the headlines you need to know across medicine, law, sports, schools, and prisons. And then we dig in. The three of us, and most weeks, a guest worth hearing from. We built this show because we believe that the most important conversations about gender politics are the ones happening between people with real stakes and real disagreements. Free inquiry, honest argument, and dissent that's worth something because it's actually informed. Welcome. 2 weeks ago, we brought you part one of my conversation with Dr. Kenneth Zucker, psychologist, sexologist, and one of the most published researchers in the world on gender dysphoria in children and adolescents. If you missed it, I'd encourage you to go back and start there before diving in here. This week, we return to that conversation for part two. Part one centered on Ken's new paper with Michael Bailey on cognitive behavioral treatment of gender dysphoria in youth, a direct clinical argument that psychological treatment of gender dysphoria is not only permissible, but they argue obligatory. In part two, we're discussing yet another new paper. This one is titled, Is Rapid Onset Gender Dysphoria in Adolescents a New Clinical Phenomenon? Which takes on one of the more contested questions on this entire debate. We will link to both papers in the show notes. We also get into a little bit of the places where I wanted to push harder and a few things I wanted to say directly to someone who's been doing this work longer than almost anyone. Ken Zucker is a controversial figure, including among some of our own listeners. I think that's why this conversation matters. We hope you enjoy part two. Welcome back to part two of my conversation with Dr. Ken Zucker. Dr. Zucker, you have a new paper. Is it out yet?
Yeah, it's online first now, open access, yes.
Perfect. Okay. The title is, quote, Is Rapid Onset Gender Dysphoria in Adolescents a New Clinical Phenomenon? So your paper's arguing that you think it should be formalized as an age of onset specifier in the DSM rather than remaining as a contested concept. Could you explain what changes if it's in the DSM? What's been lost by having it not in there? What is added by putting it in there?
Well, so we have to go back, let's say, at least in my experience, at least around 20 years. So let's say 2005-ish, where
Okay.
at our clinic in Toronto, we were in the middle of experiencing a general increase in the number of referrals to our child and adolescent clinic, but most significantly, it was an increase in the number of adolescent females.
You were seeing the increase back in 05, like 2005?
Yeah.
Okay.
And in 2016, we published our paper in Journal of Sexual Medicine talking about the altered sex ratio of adolescent referrals, both in Toronto and in the Netherlands, where we were basically finding the same thing in parallel. In the older days, we both saw more adolescent males and adolescent females. And the shift occurred in the first decade of the 2000s. And, since then, as you well know, everybody finds the same thing. I'd say 99% of the samples since our paper was published in 2015, everybody finds more females than males. But
By a high percentage too. I routinely see 70-80%. Is that the percentage that you were seeing?
I would settle myself on 70%
Okay.
females in my private practice over the last 10 plus years at 70%. Um, the latest study I read 2 days ago, looking at 4 gender clinics in Canada about their referrals between 2012 and 2017, 75% were female.
Okay.
So yeah.
Okay.
Now, apart from this change in the sex ratio, which I have found is basically not being given enough theoretical attention in terms of like what the hell is going on. So like this latest paper seems to want to just explain it along the lines of trans feminine phobia, which I think is too simplistic, but let's put that aside for a minute. The other big change was a good percentage of these adolescent females that we were seeing did not have the classical early onset history that we talked about last time of
Yes.
showing signs of marked gender nonconformity slash tomboyish slash gender dysphoria in early childhood. They didn't have anything. And but what they did have was a lot of co-occurring mental health issues.
Okay, let's pivot, if you will, for just a second there. So a lot of your paper talks about that these girls showing up do not have early onset indicators. But what your paper also talks about, and similarly what I saw in the clinic, is it's not just their self-report, because this is not just them saying, like, the kids might be self-reporting something different, which you talk about, which Turbin's paper talks about. Maybe like that the kids always knew, but they don't tell someone. But the other thing that your paper talks about is that what you would be seeing, the parents should have seen. It's about what toys people are picking, or clothes, or their peer group, or these indicators. There's just no history of this at all. So you said in the paper the concealment argument, the idea that these adolescents always knew, but they just didn't have the words, is probably on it. It's not what's really there.
Right. I'm generally skeptical of the concealment argument where kids might say, or skeptics of the whole idea of rapid onset gender dysphoria will say, these kids just didn't have the words to describe what they were feeling. And, one of my arguments, like you just pointed out, is there are so many aspects of gender that are observable that it would be hard not to see gender nonconformity in day-to-day behavior, who one plays with, the toys one likes, so on and so forth. I also made a point in the paper that I've seen many kids over the years who have, very extensive mental health histories, and I have reports from when they were little kids, and there's nothing in those reports about gender.
Okay, I'm going to totally agree with you on that also. So Even in the center where I was working, part of what I was trying to get the clinicians to be curious about is, okay, the kid's telling us one thing. The kid's saying, oh, this has been a problem for me since I can remember. And I was saying we should be able to corroborate that somewhere in the record. These kids were getting autism diagnoses, they were getting early services, they were having sensory issues, they were seeing therapists early. I'm like, nowhere in the record do you see this issue documented at all. And if it really was the issue that these girls were claiming it was, you would have seen it somewhere. They're kind of like imagining that a whole group of professionals just blatantly ignored something that they claim was a huge problem for them in their early childhood.
Yeah, I think we're in agreement that there's some type of reconstruction of one's personal biography.
Yeah.
And the motivation can be quite variable. So, for example, some kids might think my parents will be more likely to accept that this is who I really am than if it is something of more recent onset.
Okay, so I think we're in a lot of agreement that we saw a similar phenomenon, that this is a phenomenon that's being seen globally. The age, the sex presentation, the lack of early onset indicators. Um, I thought the paper did a reasonably good job of walking through some of the criticism, which is valid just in the study and how the Littman study was carried out, similar studies to there. Um, I think you reviewed about 13 studies. Um,
Something like that, yes.
yeah. What do you think, if you're looking at those studies, what's like the most important measures that you still think need to be looked at? What is still not being looked at?
Well, let me answer that in one second. I want to say one
Go.
other
Okay.
thing about we didn't have a label for what we were seeing. We just knew they were different and there were all of these co-occurring mental health issues, and we were trying to figure out, what does this all mean? So let's say among these late onset kids who we think they're late onset, they have autism. So we're trying to think about, could there be an explanation there? Or a kid with really poor social skills and lots of anxiety. And as they come closer to adolescence, they're feeling more and more alienated from other girls. They don't fit in, and or some type of traumatic reaction to sexuality. But Littman in the 2018 paper basically put a label on it, which she called rapid onset gender dysphoria. And I think that, why do I think it's important? So I think it's important because it's a different clinical presentation. So there's something different about the starting gate that leads to the diagnosis. Um, and that's something we call equifinality, different starting points leading to the same outcome, meaning gender dysphoria. So there's a deep theoretical reason to understand it. So in my own experience, it challenges, my earlier thinking that gender identity gets laid down very early in life, because we know gender can be very salient for preschoolers and early school age kids. And once you get on a path, you sort of stay on it, more or less. So here we have kids where they seem to have started on a different path and wound up on another path. We need to understand it. And then, of course, clinically, we have all of these adolescents coming in saying they want hormone therapy, or even more, they want mastectomies. And if we go back, to the so-called Dutch protocol or Dutch model. Well, in the early writings of the Dutch, one of the eligibility criteria was that you had to have a long-standing history of gender dysphoria. Well, these kids didn't have a long-standing history. And so does that challenge decision making about what do you do first?
Is part of the paper arguing that if this is put in the DSM, do you think it would change the trajectory of some of the clinics like assessments, that they might see it as the different phenomenon that it is?
Well, that's a really excellent question. I think that my experience is that gender affirming clinics don't really care if
Okay.
something is early onset or rapid onset. But if we don't measure it, then we will never know if a parameter like age of onset is important. As I went through the literature and preparing for this, writing this paper, which I spent a long time avoiding writing, I'm amazed at how many studies are out there of adolescents that only tell us, what percentage of their patients met the criteria for gender dysphoria at the time of assessment, which is usually pretty high, but nobody asks about age of onset. No, let me say that differently. Many studies don't ask about age of onset. So one of my hopes is this will motivate people who work in the field to start collecting more systematic data about age of onset. So then we have to get into, well, can we come to an agreement about how to measure age of onset? We can ask it in different ways, and we can ask both the youth and the parents. We want to
Yes.
collect data, and that's what we're certainly doing in the new study I'm doing with Michael Bailey and Lisa Littman. We have multiple questions that get at age of onset, and we ask parents to do it, answer the questions, and we ask the youth to do it separately. And we'll see to what extent there's agreement or lack of agreement.
Okay. So I think we have a ton that we agree upon right now. We've got this ROGD cohort. I think we've both seen in clinical practice a lot of similar things. I want to kind of run through a series of questions about this phenomenon and some of the potential different pathways into this phenomenon. So I'm talking specifically, I'm thinking specifically about adolescent onset, mostly the girls. And I kind of want to talk through what could have driven them into it, if we could go there.
Sure.
Okay. So one phrase that I hear people get really upset about, and they hate this idea, is the phrase itself, social contagion. So my understanding, the concept of a social contagion, it's using kind of a viral model where you're thinking that you have primarily an in-person peer contagion or clustering model, right? So like a social contagion, if you think about all these historical social contagions, the kids would share geographical space, they would share these peer groups, clustered cohorts. But what I think is different about our ROGD cohort, I think it's more socially mediated rather than socially contagious. So I felt like the peer group wasn't always directly in the room. The peer group was on TikTok, on Discord, on their gaming forums. in the global kind of online community that a socially isolated kid could access at 2 a.m. when their parents think that their phone is turned off. Is this, can we look at it like the classical social contagion, or is this something new, or does that matter? Does it matter if we use the word social contagion or socially mediated clinically?
I'll say I don't think it matters, and I'll add more to that. So, for example, there's a social science journal called Social Influence, which I had never heard of until a couple of years ago. So clearly, people who study interpersonal behavior, sociologists, social psychologists, etc., believe in social influence. So, for example, you can read about gang affiliations.
Mm-hmm.
If one of your siblings is in a gang, the odds are higher that you're going to join a gang.
Yeah.
Um, and folks who write about that, they might give lip service to genetics, but that's not really what they think is going on. Um, Abigail Schreier, in her book, you know, had the word craze,
Mm-hmm.
CRAZE in it. I said, "Where did you come up with this?" And she talked about hula hoops from
Oh,
from the
okay.
early 1960s. So uh, some things are socially contagious that are kind of benign. Uh, what I think the critics, what they don't like about Lisa Littman's use of the term social contagion is, yeah, like it's a virus, like HIV. Um, whereas somebody who's agnostic is, we just want to know what's going on. And uh, I think people, there are probably hundreds of social scientists these days looking at the impact of social media on various aspects of behavior, right?
Yeah.
Um, why are governments wanting to ban social media for kids under 16? Because they think it influences behavior in a way that's not healthy. And if social media influences all kinds of things, why can it not also influence somebody's felt sense of gender? And then it becomes, a separate matter. Like, is that a good or a bad thing?
But did that initially surprise you? Did it initially surprise you when you're saying you thought that it was like gender was more maybe concrete at an earlier age?
Yeah.
Did it shock you at all that these kids, that gender could be one of these things that could be socially spread?
You know, uh, here we have the problem of like uh, aging with no good benefits, which is I'm not sure that, like, thinking back 20 years ago to the kids that we were starting to see who didn't have the early history, I don't have a clear memory of peer influence being at the top of what we thought was important. And so, for example, one of my criticisms of the peer influence element was, suppose you have a little area of a city, and it turns out there are 6 kids who are all friends with each other where they're all trans. Well, kid zero uh, would not couldn't be explained as having been influenced by all of their friends if they were the first one to come out. You would have to make an argument that if they were influenced socially, it was through some other mechanism. Maybe it was online, or something else, but trying to figure out who is influencing who is very complicated.
It is. Um, you mentioned Abigail Schreier's book. I'm gonna actually bring up a different book. So I remember distinctly when Abigail's book came out, but I also really remember this book by Suzanne O'Sullivan, and the book was called Sleeping Beauties. And her book was documenting mass psychogenic outbreaks. And she was talking about these psychogenic illnesses that were primarily spreading through adolescent girls. The title of the book, are you familiar with this book at all?
No, I'm not. It
Okay.
sounds really cool.
It's amazing. So the Sleeping Beauty is that in some Northern European countries where families immigrate from Eastern Europe or other regions where they are coming from maybe war-torn or poverty-stricken reasons, these families immigrate to these Northern European countries, and the children have fallen into this sleep state where they cannot be roused, where they're basically in a coma, in a sleep state. That's the Sleeping Beauty's title, where they have this psychogenetic illness, essentially because in some ways it allows the family to not be deported. But she's documenting these real debilitating symptoms, extraordinarily difficult to treat. And I remember reading her book when I'm still in the gender center, and she never makes the leap to ROGD. I'll say that. She never jumps over there. But to me, it felt so parallel because one of the things I think that the other side hears when we use the phrase like social contagion or social mediated is that we're acting like the distress isn't real, that we're acting like they're not really in pain or really having problems. Like, oh, it's social. So, it's not real, this concept of real. Um, I sometimes am willing to put ROGD into a mass illness kind of conversion process.
Hmm.
Have you thought that that is possible? Is it too big?
Well, um, a number of years ago, a pediatrician I know who specializes in juvenile diabetes. So he spent a couple of years becoming a specialist in treating children and adolescents with diabetes, said, I have more gender patients than I do diabetic patients.
Yeah.
So how much is too much? I mean, it's always a judgment call. If it is, at least in part, socially mediated in the way you're talking about, and the general concept of contagion, the hypothesis will be that maybe it's going to lessen at some point. One of the complexities, of course, in this domain is how the external world reacts to the presentation. So, let's say the kids who are presenting with, pseudo symptoms of Tourette's,
Yeah, the TikTok tick kids, yeah.
the schools don't celebrate the kid having Tourette's.
Correct. They don't have Tourette's month right now.
They're not invited,
Yeah,
to lead LGBTQ marches.
you're absolutely correct.
Um,
Yes.
they're not going to be on the front page of the New York Times
Yeah.
uh, in the same way that trans issues sometimes uh, are discussed. So, that's a whole other layer of complexity. And, as part of that, one of my hopes is that uh, clinicians who are skeptical of the idea of ROGD will try to think more seriously about it and be curious about it. That if a kid is coming to you with a very different presentation than, let's say, you were trained to expect, uh, a curious clinician academic will want to think about what the hell is going on.
I'm afraid that they've now been trained to expect the RGD kid. Um,
Sorry, say that again.
I'm afraid that a lot of the current clinicians
Mm.
have been trained in a way to expect the ROGD kid. That's who I mean, I
You mean,
almost feel like the early onset were the rarity. They were
mm,
the rare ones. Um, I want to I want to jump into three little short areas, one of
okay,
which you might not like. So I'll give you the one you might not like last. Okay.
okay,
And then the first one, some of the parents listening might not like. So let's just upset a couple people real quick. Okay.
why not?
In the clinic where I worked, I saw some family units where there was a genuine ideologically captured parent who believed wholeheartedly, not just in affirming their kid in medical transition, but I had some parents where I seriously thought that they had some Munchausen adjacent features. They might not be like classical presentation because in a classical, I didn't feel like they were seeking for any and all medical interventions that they could find. They were dead set on this one,
Yeah.
but they were taking on this role of, they were deriving something from their child's medical identity, from the community it afforded them to enter. They were the brave parent of the trans child. Have you heard anyone in your field willing to name or assess or consider this as a clinical variable? Have you seen any presentations like this?
Well, that gets into a huge area about what are the causal factors related to the development of gender identity in any kid. So let's transport ourselves back in time to 1970, where one of the most widely accepted views about gender development was it's all due to socialization. It has nothing to do with biology, social influence, uh, feminism. Second wave feminism posited that any differences between boys and girls has to do with socialization. Now, if you accept that perspective, then you could say that that can be used to understand uh, why some kids develop a trans identity. Is it because of social influences? And that can be, that's a politically loaded issue. So back in the day, for example, if we're talking about early onset gender nonconformity, for example, in boys, I mean, Robert Stoller, who was one of the early theorists, attributed a lot of it to family dynamics, that the mothers were really into having a very feminine son. So, what I find interesting in the contemporary sample of adolescent girls, in my clinical experiences, in my clinical experience, a lot of their moms will say, we never had any constraints on gender expression in our family. Our daughter could do whatever she wanted as a girl. And so they're very puzzled why that kid is rejecting femaleness. But yes, I think that that gets into something we were talking about last time, which is in terms of help seeking. Parents come into the clinical situation with their own philosophical and ideological perspective. So there are some parents who will be of the persuasion that this is all due to negative social influence, and it really troubles them. Others adopt the born that way model. This is just who my kid is, and it has nothing to do with me or our family. So these are very, sensitive clinical issues where one has to get into it with parents in terms of trying to make sense of their kid.
If I'm imagining back though to the 1970s, and I don't want to do this. I feel like in a lot of childhood mental health concerns, it's often the moms that get blamed. But if I'm gonna just imagine back to this kind of 70s presentation you're talking about, I'm imagining a mom maybe with some young boys, and instead of only buying them trucks, she'll also throw in a couple Barbies, and she'll maybe
Hmm.
throw in a cooking set, in addition to like the fire truck. I s- did you ever have families back then who were directly, I'm trying to articulate the difference. I I could
I
see
know where you're going with it.
I feel like that's different from, one of the parents in the centers I worked in. She would set her kids down once a week and ask them to sit in the circle and meditate, close their eyes and meditate on their gender and open their eyes and magically tell them what their gender was that week. And she herself was non-binary, and all of the kids had some type of gender presentation. I had another mom with a tomboy daughter that she claimed was a tomboy, and she had ordered every single child's book she could find about trans on Amazon. And she said, I sprinkled them through the house so her daughter could just have trans literature at all times. I feel like that's somewhat different. Adding a Barbie or adding a kitchen set and talking to kids about your gender might be different, but in some ways, I guess it's both influence. But do you feel like there's at least some kind of difference?
I know where you're going with that. I mean, Gavin Newsom's wife uh, was so proud in a recent interview to say how she buys their sons dolls, that she's this modern, liberated mom, even though she's talking, you know, what people talked about like 50 years ago. So, anyways, um, no, I think what happens is that, gender is a very complicated, I think, socially constructed process that has a biological underlay to it. And so, for example, in the old days, we would see some families where their model was, non-sexist child rearing. So they didn't want to put any gender constraints. But in the case of the little boys, one thing led to another. And all of a sudden, the only thing the little boy was interested in was Barbie dolls and dressing up in the mother's clothes and role playing as a girl. And as one mother who was a very strong adherent of non-sexist child rearing said, I'd kill for him to pick up a football once in a while.
But I've heard, I will admit, I'm I was born in the 80s. I mean, I've heard the records. There's an amazing record that Turbin, I think, stole his book title from. I'm gonna turn to look for it. Is it in here? Oh, Free to Be. There was this, this record
Right.
out, Free to Be. I still feel like when I was listening to that, they the songs acknowledged there were sex differences, but that those shouldn't be limiting to your roles in work or, helping and clean, who can clean and who can do these things. I just felt like that maybe I'm just retrospectively
No,
finding
absolutely.
it
Back
liberating.
back then, Sandra Bem, who was a psychologist, she passed away a number of years ago now. She popularized the concept of psychological androgyny, where boys and girls, men and women, should be able to do whatever they wanted, but at the same time, back then, uh, she valued femaleness and valued maleness. You teach kids, boys have this anatomy, girls have this anatomy, but it doesn't matter. You can do whatever you want. So back then, trans was not part of the the discussion.
Yeah. Okay. And let's do this. Let me ask you the questions that I think you might find challenging, and then we're going to move to kind of the end and we're going to go back to true trans and who should be medicalized. So let me ask you this one first.
Okay.
So your paper talks a little bit about how it looked like you gave some room that there could be some ROGD boys. There's some
Hmm.
opening in there. I want to ask you about the boys specifically. We know they're a small cohort, but I've heard from parents of the adolescent males, and they struggle with this automatic application of an autogynephilia kind of framework on their sons. And they feel like that their boys have grown up in a different online environment than we historically saw. So they see that their boys have grown up in a porn saturated environment. They feel like their boys are groomed in gaming communities, in the fact that gender ideology is taught in schools. And they think that their boys are often disassociating from their bodies in ways that look nothing like a 50-year-old man with a transvestic history. Do you think that the AGP framework describes this new cohort, or do you think that it could be that there's something clinically distinct happening that the field doesn't have great language for yet?
Me personally, the latter. Um, and in fact, in the paper, I make my argument that one needs to distinguish late onset gender dysphoria with autogynephilia. And in that case, I view it as different from what I would consider ROGD in males. So there isn't the co-occurring autogynephilia. If it's co-occurring, then I think there's no point in trying to give it
Suss
a
it.
different, yeah.
Do-
I have
And you
no
think
trouble
that
with that at all.
the way to get to that, though, is to actually be direct with these boys and ask and talk about it?
Well, in my clinical work over many years, I think I'm pretty good at talking to adolescents about sexuality in a developmentally appropriate way. And with autogynephilia in general, if an adolescent or young adult acknowledges autogynephilia, I can't see any reason why they would invent that they experience their sexuality in an autogynephilic way. But the kids who, let's say, deny having autogynephilic experiences, it could be they may be quite accurate that that's just not part of their sexuality.
I
Then there
I
may be
worry.
others who just are not yet ready to acknowledge it. So
Okay,
that very takes time to see how things evolve.
I worry though, that even the boys, like even somebody in adolescence or like in their 20s, like taking on this, oh, I have AGP. Um, I do see sissy porn and the porn driver. Like I feel like in ROGD, you could manipulate the environment around an adolescent enough that they would think that they're trans, but I also think you could manipulate the environment around an adolescent enough through this massive onslaught of porn that makes them think that is their
Well,
orientation.
one thing that's very interesting as you're talking about this is I see a lot of adolescents, both female and male, who report having no sexual
Yeah,
feelings.
yeah, yeah.
And, for those who work in the area of asexuality, they might say, well, that's another sexual orientation. Whereas I'm more intrigued by why is a 19-year-old telling me that they've never experienced sexual arousal? They have all of this other stuff going
Because
on.
they're so disembodied, because they're not in their physical body. We have pulled them away from, you know, sorry, I just jumped in, but some of the kids in the clinic, I actually thought, it would be better for them. It would have been better for them to not have a cell phone and to have a reckless friend who was going to drive them to the mall where they'd sneak cigarettes out back and be kissing girls. Like, I felt like that was better than how disembodied and how online these kids were. But I'm sorry, I interrupted you.
Yeah, it sounds like a great plan.
Give them all cigarettes and send them to the mall.
You could set up shop in the alley.
But I wanted them to be more in real life.
Yeah.
And when you're saying all these kids claiming that they're asexual, I also just see that as very disembodied.
Hmm.
Like, and that worries me for our kids. I want them to
And so
experience
we have these kids who have no sexuality, and then we put them on hormones.
or SSRIs also, which affect and dampen
Absolutely. Yes.
sexual function as well.
Yeah.
Okay, here's where I want to go at the end. This is where we left off last time. This is where I want to go, and then I'll let you get back to work. So, at the very end, last time I asked you, does the category exist of true trans? If it
Mm.
does, how do you define it clinically? What does it look like developmentally? And how confident are you that the current system is actually able to identify it?
Yeah, I don't believe in the concept of true trans. I believe in I believe that gender dysphoria is real and diagnosable. As I say to many parents, making a diagnosis of gender dysphoria for me is the easiest part of what I do. The more challenging and clinically important issue is what is the developmental course going to be of your kid's gender dysphoria. Now, if we go back to little kids, in the old days, based on the literature, one conclusion one could make, this is, a little provocative, but one could say, if you don't socially transition your kid, the majority will desist. If you socially transition your kid before puberty, they're going to persist. So there are going to be two main pathways into adolescence and adulthood, and parents have to think about what what works for them. With adolescence, where I feel the field is at, is that we just don't know enough yet about the longer term gender developmental course of kids who I think fall under the ROGD umbrella. Now, here's this little study that just came out this week, 4 gender clinics in Canada, and they're talking about around 450 adolescents seen by pediatric endocrinologists uh, connected to these programs. And so the vast majority of these kids who wind up seeing the endocrinologist go on some type of hormone therapy, whether blockers, cross-sex hormones, or both. And at a median follow-up of 2.5 years, which isn't that long, they report that 95% continue taking the hormones. And they talk about how this shows the stability of a transgender identity. This stability percentage of 95%, is not entirely surprising to me because some of the critics of the Tavistock Clinic say, well, they put them on blockers to give them time to think, but almost all of them wind up on cross-sex hormones. Whereas if they had time to think, you would think at least some of them wouldn't go on to cross-sex hormones. But what's really interesting about this paper, which you wouldn't know from reading the abstract, is that an unknown number of adolescents seen at these 4 clinics did not get seen by the pediatric endocrinologist. So there were 445 who were seen, but the paper doesn't tell us how many weren't seen. And it's those kids who I would really like to know about. Like, why didn't they go see the endocrinologist? And what's happened to them 2.5, 3 years later? And you wouldn't realize until you got to the discussion that there's some unknown additional number of kids who don't wind up with the pediatric endocrinologists. And we want to know about them just as much as we want to know about the ones who do.
Okay.
So I'm not a fan of the idea of true trans. I think about it more as persistence and desistance.
Okay. So let me take your theoretical framework then. So we're going to throw true trans out the window and we're going to say that in your model, gender dysphoria is real.
Correct.
Okay. And if we're talking about gender dysphoria in an early onset prepubertal kid, your 2 pathways are if you do not socially transition them, they are most likely to desist. And I would add here, and most likely to end up as a homosexual. But if
Agreed.
we do socially transition them, then they will not desist, and that outcome would be transition.
Continued transition.
Okay. So then I guess my question back is, if you believe gender dysphoria is real, do you believe that a social transition which persists and then remains in a trans identity is a good medical outcome?
Well, that's a value judgment, right?
But
So let's say a kid persists in their social transition from early childhood into late adolescence. So they're continuing with a transgender identity.
that's
Let's
that is
say
not,
that
but they weren't social, but this is they're remaining in that identity, even though taking into account they're socially transitioning themselves.
No, so let's talk about a group that has socially transitioned in early childhood.
Okay.
So let's talk about males. So they're living as, quote, girls. They continue to live as trans girls in adolescence. And you're asking, is that a good outcome? Well, let's say that these trans girls have terrible mental health. And then let's say you have an early onset boy who desists and has very good mental health. Well, it wouldn't be hard to decide which is the better outcome. But let's say you have a trans girl who persists and has very good mental health, and you have a early onset boy who desists, is gay, and has terrible mental health.
I think the part of the equation when you said that's a value judgment, I think I do value, though, that I still think that medicine should not harm a healthy body. So, if in your paradigm there's no medical once you add that medical component, that medical pathway, I don't see how that has a positive outcome to the physical body.
Well, it's a really important point. And when this point is discussed, I always, for some reason, remember a paper that was published by some Swedes back in 1961 regarding adult transsexuals. And back then they used the word transvestism for some
Mhm.
reason. And they said transvestism resists psychiatric treatment. So the idea of hormones and surgery back then was kind of viewed as the last option. We tried this, we tried that. This is all we've got left in the toolbox. And, I also think about some of the contemporary critics of gender affirming biomedical treatment who say we're putting kids on a pathway where they are going to be infertile and or sterilized. And why don't we talk about this more? Yes, we have that as a quote risk in our consent form, but we know, what does a 14-year-old really know about what their future childbearing desires are going to be? And we know from some of the studies out there to date, almost no adolescent takes advantage of fertility preservation. So should we not be talking about this more? Uh, why do the quote liberal progressive clinicians who are often part of gender affirming care why doesn't it bother them that they could be putting kids on a pathway where they're going to be sterilized? And I know what the counter argument is. It's going to be, well, we've talked about it with them, we've talked about it with their parents, and plus the kids say they don't want kids, or if they do, they'll adopt. But I think this very tricky issue has not been unpacked enough. Was it talked about much in St. Louis back in the day?
Um, I did talk to kids. We did talk to kids about fertility, and they gave the exact same kind of blasé, nonchalant, if I do want kids, I'll just adopt. And I always found that so naive on their part as an adoptive parent. But I guess if we're still operating in your model that gender dysphoria is real,
Okay.
how I guess I'm just still I just wonder, how do you still move, would you still move someone forward to a medical pathway as an adolescent?
I would say that in my own clinical work, uh, I've started to talk about this at meetings a few years ago. I'm a centrist, I think, because I am not a immediate gender affirming person where I see somebody for a half hour and say, yeah, go see your family doctor and go on hormones. And then uh, on the other end, I don't rule out the idea that after appropriate exploration, assessment, therapy, if gender dysphoria doesn't resolve, I'm not opposed to uh, a trial of biomedical treatment in a sequential way where one initially starts with treatments that are partially reversible. And am opposed to starting with treatments early on that are completely irreversible. And I think that any of us who work in the field seeing patients every day knows there is a variation in outcome. Some persist, some desist. The other day on Therapy First, uh, Anastasis Spilatus gave a really nice presentation about a patient that he worked with for years, born female, who had all kinds of mental health issues, so on and so forth. They worked through all kinds of things. And at the very end of the little presentation, talked about how as a young adult this person physically transitioned. And even though they worked through lots of other issues, this person eventually chose to start taking tea and had a mastectomy and so on and so forth. So, you know, as clinicians, we have to be humble. We know that nothing nothing is clear cut in terms of the outcomes. It's not 100% this, it's not 100% that. And as I may have brought up this story last time, I don't remember, but there was one kid I worked with for a couple of years as a teenager who desisted. And when the parent asked the kid, so what was it all about? And the kid said, it was no big deal and everything's cool. So we just have to be humble and keep pressing away uh, at the complexity.
I I think on some element I just have too much of a kind of a cultural anthropologist in me, where I think even the way we conceptualize, even that concept that gender dysphoria is real is so culture specific and time specific, and what people are, what's around you. And I still have hope that we could build a world that could so embrace gender nonconformity and homosexuality in a way that would not pathologize either of those things and embrace them from an early age, that would remove that that distress around our bodies, our sexed bodies, in a way that would make it so we don't even need that diagnostic pathway anymore.
You are a postmodern Sandra Bemian. I am totally sympathetic to where you're coming from.
I never thought I would be called postmodern, but yes. Um, Two more questions. Sorry, I just want to pick your brain a little bit more. Do you think at all that persistence in young people remains because the medical model remains on the horizon? I think that in a way comes back to cultural. If that didn't exist as a yellow brick road that was there, does its existence itself as a model lead to more persistence?
That's a really interesting question. So during the DSM-5 period, uh, Peggy Cohen-Kettness, who was the chair of the gender identity disorders subwork group, would make the argument that not all of the adolescents they saw in Amsterdam were distressed about their gender. And I would always argue they have to be distressed about something. Otherwise, why are they coming to see you? Um, and what Peggy would say is, well, they know that if they come to see us, they're going to get hormones. So therefore, they're not distressed. Though I would say, yeah, but the fact that they want hormones means they're distressed about something. But yes, uh, and then that gets into a very interesting issue. What if it turns out that, say, in the US, where there are now going to be some states that have restrictions on access to biomedical care for minors, might that result in an increase in desistance? The kid says, well, this is just not worth it. I'm going to try something else. We have no idea.
Okay, my final question. And I hope,
Uh-oh.
no, it's not bad. And I hope we can talk again, especially as you continue to write. You've been in this field now, would you say 50 years? Has it
Yeah,
been years? Okay.
51 this year.
You've watched it change in profound ways that I can only imagine that you did not anticipate, that it has gone in directions you never thought possible. Um, we're of a different age. Do you have a hope for 50 years from now? Is your name remembered for somebody who just tried to follow the science? Or what do you hope for 50 years from now?
Well, I'd love to still be alive to find out what happened. One of the things that I find really amusing when I read criticisms of some of the measures I've developed is uh, they're either called offensive or outdated. So I even made a button a couple of years ago that says, outdated on it, which I'm, very proud about because at least I developed a measure.
That's now
Uh,
outdated.
so, it's a great question, Jamie. We have to do that like podcast number 3. I
Oh,
have to
Lord.
think about it, give it some serious thought.
Well, and one of the reasons why I ask you this is because I've been really deep in writings about Magnus Hirschfeld.
Mm,
And I feel like there was a period of history where he was almost forgotten and then brought back as kind of a gay rights activist kind of savior. His name is getting pulled back into these
mm.
debates around gender and I just think one, it's hard to judge people in the future based on their historic era. Um, but also I I think about individuals who've been in this for so long. Um, recognizing that this is not a 1 or 2 year debate. This is not the legislation's going to pass a law and it's done. This has been a question that I think is not going anywhere anytime soon. How do we raise our kids? How do we raise our kids in sexed bodies? How do we deal with homosexuality? How do we deal with expectations of how we interact within the world? Those are salient questions that aren't going anywhere. And then I think the questions about what is medicine, what should it do to the body? I just think that your impact, I think 50 years from now, where are we going to be at with these conversations?
Well, I'll try to get internet in my casket, and you send me your podcast
I will.
in the year 2076 so you can tell me what happened.
I don't even know if I'll be around by then, but yeah.
The world needs you, so don't go away.
Oh, thank you. You as well.
I gotta go.
Okay. Thank you so much for your time. We'll talk again soon.
Bye.
This podcast is produced by the LGB Courage Coalition, a registered United States nonprofit fully funded by small donations like yours. We work to promote evidence-based medicine, ending the medicalization of gender nonconformity, and advocating for LGB rights. Supporting this show means supporting that work directly. If what you heard today mattered to you, please like, subscribe, and pass it along. Word of mouth is how independent shows like this one survive. You can reach us in the Substack comments section or by email at lgbcouragecoalition@gmail.com or through the contact page on our website at lgbcourage.org. We want to hear from you. And until next week, stay informed and ready to dissent.